Hello everyone, welcome to my YouTube channel. Our topic today is about breast cancer pain. These are the objectives of our presentation. We'll start with the prevalence of breast cancer pain. Breast cancer pain doesn't, in fact, actual breast cancer doesn't usually hurt. Research shows just 6% of people diagnosed with breast cancer report breast pain as a symptom. However, a rare type of cancer known as inflammatory breast cancer can cause breast pain. Breast pain is more likely due to hormone fluctuations from puberty, menstruation, pregnancy, or menopause. Studies have consistently shown the incidence of post-mastectomy pain syndrome to be around 50% between the 24 and 36 months post-operative. Total pain, that's the definition put forward by Dame Cicely Saunders. As she suggested, pain can be understood as having physical, psychological, social, emotional, and spiritual components. The combination of these elements is believed to result in total pain experience that is individualized and specific to each patient's particular situation. Total pain, physical, non-physical, spiritual, emotional, and social. We'll focus today on the physical one, and particularly the neuropathic pain. Neuropathic pain, by definition, is the pain arising as a direct consequence of a lesion or a disease affecting the somatosensory system, whether it's a central or peripheral. This is basically the WHO analgesic letter that was introduced in the mid-80s for chronic cancer pain. Now it's been modified to include also acute pain and to include also step 4, which is basically procedural, like nerve blocks, epidurals, PCA pumps, spinal cord stimulators, and neurolytic blocks. Acute, transitional, and chronic pain. I'm sure all of you are aware about acute pain. Acute pain is the pain that resolves with healing of a causative injury and has a protective biological function to protect against further injury. Most authorities consider pain that's less than 2 weeks to be acute. Chronic pain is a pain that's lasting beyond expected recovery period, and identifiable pathology is insufficient to explain the pain state. It disrupts sleep and normal activities of the living and doesn't serve as a protective or adaptive function. Chronic pain by most authorities is the pain that persists beyond 3 months. Now we have something also called transitional pain. And there's a lot of interest on transitional pain in the United States right now. And basically, transitional pain care is focused on treating patients who are at risk of transitioning from acute to chronic pain following surgery to prevent the development of chronic pain and related disability. We have this service in some of the large institutions in the United States, like Johns Hopkins and others. And basically, they focus on, dealing with these patients that have a high risk of transitioning from acute to chronic. Types of neoplasm-related pain. This classification was put forward by Dr. Foley. We have acute neoplasm-related pain. We have chronic neoplasm-related pain. We have treatment-related pain. We have patient with a history of pre-existing pain. We have patient with a history of drug abuse and dying patients. So we have 6 categories of pain, of neoplasm-related pain. We're going to focus today more on the treatment-related pain. For example, post-chemotherapy pain, chronic post-surgical pain syndrome, and chronic post-radiation therapy pain syndrome. So, as you know, chronic peripheral neuropathy, especially with the Texans, AVN or femoral or humeral head necrosis, gynecomastia, chronic post-surgical pain such as postmastectomy pain, chronic post-radiation therapy pain syndromes. For example, in our situation today, it's radiation therapy brachial plexopathy. So we're gonna focus more and more on uh, post-mastectomy pain syndrome. Post-mastectomy pain syndrome is chronic nerve pain that occurs after mastectomy or other breast-conserving surgery. People with post-mastectomy pain syndrome experience consistent pain lasting for more than 3 months in the chest, arm, and the underarm area. Symptoms may include tingling, numbness, shooting pain, shoulder or surgical scar pain. The condition can persist for years after mastectomy. And it's a common problem. The pain is caused by nerve injury during surgery, and over time, the injured nerves may heal. So, post-mastectomy pain syndromes is a common problem. It affects 50%, as we mentioned early on, and it can persist for years. And it's basically a neuropathic pain syndrome. And that's why I focus on the neuropathic pain definition at the beginning of the presentation. Pain and altered sensation, breast, axilla, and chest wall. The commonest nerve affected is the intercostal brachial nerve. For those of you guys that don't know the intercostal brachial nerve, it's a branch of, the lateral branch of the second intercostal nerve. And it supplies mainly the axillary floor. Phantom pain can affect can happen after mastectomy here. And neuroma, neuroma pain can also happen, and others. Post-mastectomy pain, as we mentioned, it affects the intercostal brachial nerve mainly, and it can affect other nerves as well in this area. Other sources of post-mastectomy pain syndrome: pectoralis minor syndrome or thoracic outlet syndrome, cervical radiculopathy, scapulothoracic bursitis, what we call snapping scapula syndrome, shoulder impingement syndrome, glenohumeral capsulitis, what we call frozen shoulder, lymphedema, Stewart-Treves syndrome, myofascial pain syndrome, and central sensitization. So we'll get back to what is neuropathic pain. It's a pain caused by a lesion or a disease of somatosensory nervous system. It could be affecting peripheral nerves or central, the central somatosensory nervous system. These are kind of the symptoms that you see with neuropathic pain. Stabbing, pins and needles, throbbing pains, burning sensation, electrical shock-like sensation, numb sensations, and shooting sensation. If we even, go deeper, we have positive symptoms and signs, and we have negative symptoms and signs. There is a method to measure the neuropathic and pain and diagnose it. It's called the douleur neuropathique. It's a scale performed by some of the French physicians in 2005. This is one of the very famous ones used to diagnose, and screen for neuropathic pain. It's basically yes or no answers. It consists of 10 items. A cutoff value of more than 4 points indicate neuropathic pain. This is the questionnaire. I was able to find one in English. Look it up, please. Okay, especially if you're, suspecting neuropathic pain and you're not, able to confirm it. Postmastectomy pain syndrome, as I said, is a neuropathic pain syndrome. It can present with electrical, burning, shooting, or stabbing pain. Positive signs and symptoms like allodynia, negative signs and symptoms such as numbness and anesthesia dolorosa. Anesthesia dolorosa is basically pain after you transect the nerve. All right, it's actually a very painful condition. Intercostal brachial nerve. This one in red here is the intercostal brachial nerve, and it supplies the axilla. Phantom breast pain, it happens exactly like phantom limb pain. And this is a central sensitization process. It's a cortical phenomenon. And that's why the only way to treat it is basically, is to give medications like gabapentinoids and so forth. There are procedures, but these are pretty investigational up to now. Like putting, like a spinal, like a motor cortex stimulation and stuff like that. I mean, these are basically for research. Chronic pain following breast surgery. Breast cancer surgery, 50%. Mastectomy, 50%. Breast conserving surgery, 50%. Breast augmentation, 10 to 40. Phantom breast pain is 5 to 10%. Features of chronic pain after breast surgery. Daily pain in 50% of cases, moderate to mild to moderate, 90%, severe, 10%. So, I mean, not all the cases that you're going to see in the clinic are severe pain. I mean, you can have mild to moderate cases. And actually, this is the majority of patients, 90% of the patient. And 10% only will have severe pain. Widespread, 40%, something like similar to fibromyalgia. Regional, like neck and shoulder, in 50%, axilla or arm, 60%, and chest wall or breasts in 70%. These numbers are useful for you to, have in your mind. Chronic pain syndromes. We have secondary pain syndromes such as frozen shoulder, neck and shoulder myofascial pain, lymphedema, CREPS, cancer pain syndromes like local invasion, metastasis, and treatment effects like neuropathy. Risk factors for chronic pain, high BMI, younger age, pre-op pain, like a patient, for example, having breast pain before surgery, or fibromyalgia patients. Severe acute postoperative pain is another risk factor for chronic pain. Remember, we have this new transitional services that work on these kind of, you know, patients with risk factors for chronic pain. Complex surgery, like revision or reconstruction, nerve injury from axillary dissection, radiotherapy or chemotherapy, limb immobilization, such as frozen shoulder or complex regional pain syndrome, and lastly, lymphedema. So the transitional services will pick up these patients and will treat it aggressively so they don't get from acute to chronic. Risk factors for breast pain, it's under the mnemonic TINT, tumor recurrence, infection, neuropathic pain, and trauma. Psychological risk factors, CHAMPS, catastrophic thinking, lack of family support, anxiety and depression, patients that are medically focused, passive coping style, social support is lacking. Prevention of chronic pain. Avoid unnecessary surgeries such as cosmetic surgery, surgical techniques like nerve sparing procedures will definitely reduce the incidence of chronic pain. Screen and monitor at-risk patients. Preventive analgesic techniques, multidisciplinary rehabilitation. And these are the breast cancer pain checklist. CAM therapies, behavioral therapies, physical therapies, pharmacological pain interventions, surgical interventions, chemotherapy, and radiotherapy. We'll start with patient-controlled analgesia. This is becoming, very important for patients that might have, post-operative pain. Okay, we use it all over here right now in Egypt, in most, ambulatory centers. Regional anesthetic techniques. So you don't have to memorize the procedures itself. I mean, the technical aspect, but I want you to understand the concept, please. So there are central regional techniques and there are peripheral techniques. Central means that you're very near to the center, which is the spinal, like epidural blocks, paravertebral block. These are the gold standards, okay? These are the highest quality blocks that you will get. Unfortunately, they have higher complication rates. While nowadays, most anesthetists, they prefer the peripheral blocks because despite their lower quality of analgesia, they're much, much safer and easier to do than central blocks. You can do them even in patients who are on anticoagulants and patients that have, any sort of spinal cord injury. So this is like a thoracic epidural, the gold standard. Again, you have the cord. You can injure the cord, or you can cause epidural hematoma or other problems. Paravertebral blocks is just next to the thoracic epidural. A little bit safer, but still, you can still have a lot of complications from this procedure. I remember back in the 90s, we used to, do thoracic epidurals for all these breast surgeries. Now we have new blocks that started to show up like maybe 10 years ago, like erectospiny plane block. These are very far away from the spine. You're actually doing this block at the tip of the transverse process. And we have another one which is super simple. It's called serratus anterior plane block. So if you have any one of your family members going for these surgeries, please ask for these blocks. Okay, they're much safer than the thoracic epidural. And there is a study here where they compared effectiveness of serratus anterior plane block and erector spiny plane block to the power vertebra blocks. And they found that the serratus anterior plane block was extremely useful. Anyway, I'm just kind of mentioning this because if any of your family members or loved one going for breast surgery, I mean, they can ask for supplemental, a block like the serratus anterior plane block from the anesthesiologist. And this is a 2-minute procedure. All right. Gives you less quality of analgesia than the thoracic for sure, but it's way, way much safer. Serratus anterior plane block. Look at the territory that's blocked after this injection. Simple shot with an ultrasound probe here. Okay, we'll jump into another thing here, intercostal brachial nerve block. And this is, where we block the nerve that's commonly injured, after mastectomies, radical mastectomies. Suprascapular nerve block, we use it for shoulder pain. Shoulder pain is commonly affected, and I mean, it's commonly, it's one of the common things that happen after breast surgeries. And we're going to explain why. Suprascapular nerve block would be a good choice, and it's pretty safe to help with shoulder pain. One of the complications of breast surgery is long thoracic nerve palsy, and this can give you pericapsular shoulder pain, winging of the scapula. And usually this ends with a pectoralis major transfer. Okay, I'm going to show you some of these things that affect the shoulder. There's a syndrome called scapulothoracic bursitis or snapping shoulder syndrome. Every time the patient moves his arm, you will have this snapping noise. And it's very simple to inject, in fact, where you just put your needle underneath the scapular blade and you put your steroids there. Also, another complication is adhesive capsulitis. Okay, I'm not sure why adhesive capsulitis follows, post-mastectomy, but there is, some of these patients will develop it. And it goes actually in 3 stages, from stage 1 to stage 3. Usually it starts with the severe inflammation of the shoulder joint, and then 3 to 9 months later, the pain starts to subside, but there's more stiffness in the shoulder joint. And then stage 3, which is from 12 to 24 months, the pain and stiffness and overall symptoms gradually subsides. So when the patient comes to me in the clinic, I always tell him that I have bad news and good news. The good news that this will disappear within 2 years. The bad news, you'll be hurting for some time here, and to accelerate the healing process, we need to give you some treatments. One of them is like suprascapular nerve block. You can always give him anti-inflammatory drugs and so forth until you get into stage 3 of the frozen shoulder. Another condition that we see with, in the post-mastectomy phase here is cervical radiculopathy. And basically, the commonest nerve affected is C6 nerve or C7. Chemotherapy-induced peripheral neuropathy. There is a famous syndrome called the TAPS, or taxane acute pain syndrome. It's commonly an early toxicity associated with taxane-based chemotherapy, such as paclitaxel and docetaxel. It might affect the quality of life. And right now, we don't have really a gold standard treatment for TAPS. except giving some of these, pain pills, NSAIDs, opioids, steroids, and gabapentinoids. Also, another complication or another treatment-related pain is radiation-induced plexopathy. All right, look at this patient, brachioplexus, after radiation. This patient definitely developed brachial plexopathy, and this is basically a brachial plexus, as you know. Uh, you have to differentiate, between radiation-induced plexopathy and a tumor involvement. Usually, the radiation-induced plexopathy happens in the upper part of the corpse, not the lower parts. The lower part is usually a tumor involvement. So if you have a patient that's having Horner syndrome, lower brachial plexus involvement, and hand weakness, this is probably tumor involvement. But if it's the upper brachial plexus, this is probably radiation-induced plexopathy. This is a very important board question, by the way. Osteoporosis. Osteoporosis, is usually silent, guys. All right, until you have a fracture and it starts to hurt. All right. There are risk factors in patients with breast cancer, like premature ovarian failure from chemotherapy, ovarian ablation, or impaired gonadal function from some of the hormonal therapies like gonadotropin and androgen blockade, or estrogen blockade like tamoxifen or aromatase inhibitors. I have a quiz here for you guys. A 55 presents to the pain clinic with complaints of diffuse pain in her body for 1 month. She was diagnosed with breast cancer 1 year ago and currently has osteoporosis, GERD, and hyperlipidemia. She's currently on pharmacological therapy. Which of the following drugs could be responsible causing all these symptoms? So it is tamoxifen. Lymphedema. This is another complication can occur after mastectomies. And I have a quiz here. A 50-year-old woman presents with complaints of swelling in her right arm. Started 2 months ago, but is progressively getting worse. She has a right-sided breast cancer, and she underwent surgery 20 years ago. Around 2 months ago, she was diagnosed with metastatic lung cancer and now on palliative therapy. On examination, the swelling is localized to the right upper limb with pitting edema. Which of the following should be avoided in the management of this patient? Manual lymph drainage, compression bandage, diuretics, pneumatic compression with electric pumps, and E is lymph physiotherapy. The correct answer is diuretics. Diuretics has no place whatsoever in lymphedema. Okay? Please, guys, this is maybe the most important question in the lymphedema chapter. So please, memorize it. If anything, I will memorize this question for the board exam for the lymphedema. Okay, there's another condition called lymphangiosarcoma or Stewart-Trepp syndrome. And this happens years after you develop lymphedema, all right? And is, associated with subcutaneous nodules and really has a very poor prognosis. And usually they have to amputate the limb as a treatment here. CREPS, complex regional pain syndrome. This could be associated with, postmastectomy pain syndrome. And it has a criteria called the Budapest criteria for CREPS, which is basically four, categories: sensory, vasomotor, pseudomotor, and motor. I have a full presentation about CRIPS. Please look it up in the YouTube channel. I have a quiz here. Which of the following statements is false regarding CRIPS? CRIPS has a higher incidence in younger individuals. Actually, it happens more in elder, like 16 years and more. I want to say that it happens also more in females more than males, and it's characterized by dystrophic pain, dystrophic changes, disproportionate pain, and it's basically a diagnosis of exclusion. Post-traumatic myofascial pain syndromes is another condition that we see in post-mastectomy, and I've seen a lot of these in my clinic. And I want to tell you that most pain physicians, are undertaught about myofascial syndromes, and they do a bad job with that part. So there's been a interest in ultrasound guided trigger points. So what is the false statement here? That there are randomized control trials. No, there's no randomized control trials comparing ultrasound guided trigger point versus just clinically detected trigger points here. However, it seems like it's safer, especially in the thoracic area. Also, there's a nice lecture here, a nice article about trigger point injection for post-mastectomy pain. And these guys, they found that the area that's beneath the breast here at the T4, T5 thoracic levels are the most painful area, after mastectomies. Trigger points. Also, scar infiltration is a common injection that we like to do. Pulse radiofrequency, we do it for chronic patients. Pulse radiofrequency is a modality where basically magnetize the nerve. It's not, we don't burn the nerve like the conventional radiofrequency. We just magnetize it. And we can also apply it on the dorsal root ganglion. All right. And it's pretty safe because you're not burning the nerve. All right. So this is a comparison between conventional and pulse. Unfortunately, conventional radio frequency, you really burn the nerve. And this can lead to neural destruction and can lead to neuroma formation. And it can lead the patient to be having more pain than the original pain. This is not commonly happening, but it is a problem. Also, with conventional radio frequency, can injure the motor nerve. So let us say you're working on the intercostal nerve. I mean, if you injure the motor fibers in the intercostal nerve, you can produce basically a hernia, okay, ventral hernia, because the intercostal nerves has motor nerves that's going to the abdominal muscle. So I prefer pulsed radio frequency, especially in certain areas like the dorsal root ganglion, any area that has motor nerves like suprascapular nerve and so forth, intercostal nerves. ICMB is intercostal nerve blocks and so forth. And it is basically virtually painless, except from the needle aspect here. Palliative radiation is a shortened course of treatment which will usually induce enough tumor shrinkage to relieve symptoms. And we use it in bone pain, spinal cord compression, fungation, like cutaneous spread, a relief of obstruction, like superior vena cava obstruction, brain mets, or to reduce tumor bulk. And this is a quiz for a patient with metastatic breast cancer and asking you about doing radiation to the brain. And the correct answer is radiation in this setting may extend the prognosis to several months. what we call whole brain radiation. Palliative chemotherapy is given without curative intent, but simply to decrease tumor load and increase life expectancy. For these regimens, a better toxicity profile is generally expected. Minimizing potential toxicity is the goal. Try not to compromise on quality of life. Dose reduction to avoid toxicity is permissible. Key learning points. Studies have consistently shown the incidence of post-mastectomy pain syndrome, or PMPS, is to be around 50% postoperatively. Pre and postoperative pain, complexity of the surgery, and radiation/chemotherapy seriously increase the risk of pain. The pain is extremely variable, mild to moderate in 90% of cases, and it's severe in 10% of situations. Pain can be treated using multidisciplinary technique, including behavioral physical therapy, pharmacological, and interventional pain injections. Thank you.